question, please put it in the chat or raise your hand. We shall get an opportunity where we shall give you a chance to ask your question. And in the event that your question is not answered, you don't have anything to worry about. We do pick these questions and we address them in, we do run podcasts monthly based on the things that we have discussed, and we aim to answer those things that were not answered along the way. So don't fear to ask any question, and don't worry in case your question is not attempted. As a disclaimer, these sessions do not replace clinical judgment. They are educational series that help us to get better knowledge. Obviously, knowledge translates into clinical practice. So do not change, or what you learn here should not replace clinical judgment. It should enhance clinical judgment. So once again, you're welcome. These sessions are sponsored proudly by Seed Global Health, and we collaborate with different universities that bring aboard Gulu, Makerere, King Caesar, KIU, the different universities that are represented here. They're all welcome. And we do have an EMT arm that is mainly Lubaga and in Zambia. So we do share those sessions with them. You're welcome to this session. I'll do a quick introduction of the people that are running with us today, our board, our platform. So we have Dr. Hamisis Shafi. He will be our expert for the session. He's an emergency physician that will let us know what he does, but proudly associated with City Ambulance and now hospital. And our presenter today is Talema Ignatius, medical student year 4. I think you're now year 5 at Gulu University. No, Mbara University. And then we do have Chirabo Angel, who will be our EMT or pre-hospital presenter for this case. So once again, you're welcome. And our theme for this month or for this week is an irregular pulse. So sit back and be ready to enjoy this case as it unfolds. Over to you, Angel. You're welcome. You'll do a quick introduction of yourself, and then you will take us through how you manage this patient in the pre-hospital setting. You're welcome. Angel? Okay, so let's move to the next slide that is showing us the presenting complaint of this patient as we wait for Angel to unmute. Yes, so that team today we are having an 87-year-old female who had a 2 weeks history of lower limb swelling and vomiting for 2 weeks. So this patient had a pre-hospital care and led by Angel Chirabo. I hope she's able to unmute and lead us through. Angel? Angel, kindly confirm that you're on the call.
So we had an 87-year-old female who presented with lower limb swelling for 2 weeks and vomiting for 2 weeks. Yes, so this was a community transfer and we needed a type C ambulance because she was an elderly patient, so anything could have gone wrong. So I opted for a type C ambulance. My crew, I needed 1 EMT myself and just 1 emergency driver. For the equipment, I needed personal protective equipment because the patient was vomiting to protect myself from any infections. I needed nasal prongs, a stethoscope for any diagnostics to listen to the heart, a BP cuff to check her blood pressure since she was elderly, a thermometer and a pen torch, and also an IV set in case I needed to connect IV fluids. Yes, for my ISBA report, I'm Angel Chirabo. I'm an EMT dispatched from Ministry of Health to the community for an 87-year-old patient who was cautious. For the situation, the patient was found home alone. by her relatives. She was complaining of bilateral lower limb swelling and she was vomiting with some difficulty in breathing, especially while lying down. Then she is a non-hypertensive for the past 9 months, for the past 9 years. However, she has been weaned off antihypertensives for the past 6 months, and she has a history of peptic ulcer disease for the past 4 years. The history was from the relatives. Then on assessment, I found out that her air was patent. However, she was breathing fast at 32 breaths per minute. Her extremities were warm. Her pulse rate was 94 beats per minute with a cup refill of 2 seconds. When I measured her blood pressure, it was 119 out of 73 and a GCS of 14 out of 15. I checked her random blood sugar, it was 8.4. So for my recommendations, I recommended that she sees a physician, her vitals are monitored, especially the oxygen saturation since she had a tachypnea. Then I also recommend that she does an ECG and a chest X-ray. They take off some blood for CBC, troponin, since she's an elderly patient, a urea breath test, and H. pylori since she was vomiting for the past 2 weeks.
Okay, thank you so much, Angel. So that's what happened during the pre-hospital care, and while the patient reached the emergency room, uh, a team in which Talema was involved took over the patient, and he will carry us through over what transpired during the emergency department care. Over to you, Talema.
Okay, good evening, everyone. I'm Talma Ignatius, a medical student in my fourth year and the current president of Mass Emergency Medicine Interest Group. I took part in the management of this patient. On receiving this patient, the 87-year-old female, her airway was patent but at risk. She was in respiratory distress with a respiratory rate of 32 breaths per minute with an SpO2 of 92%. She had bilateral equal air entry, but with basal crepitations. She had warm extremities, a capillary fill time less than 2 seconds, pulse rate of 94 beats per minute, blood pressure of 119 out of 73 millimeters of mercury, an irregular pulse, and a systolic murmur at the mitral area. She was speaking inappropriate words. She had a bilateral grade 3 pitting edema, but with no bruises. So,
Okay, thank you so much, Talema. Dr. Hamis, you've listened to how this patient was received right from home by the pre-hospital team down to the emergency room. And yes, that's what the team was able to do, but would like to know what are your thoughts and what would you have done differently if this patient, uh, either you are in the pre-hospital aspect as the physician or you are the physician in the ED, how would you guide us through the care of this patient? Dr. Asuman? Dr. Asuman?
Yes. Sorry. I've been muted. Yes. Thank you and good evening, everyone. It's a pleasure of being here in this kind of session. Very interesting case scenario, and yes, it's for us to learn from and to see how we can better our management at emergency department. Yes, I've heard from Chirabo, the Chirabo, yeah, the EMT, and the ED doctor who received the patient. EMT did well, of course, that's what recommended. But what I could also add on that, in case you are called in for any case, because you don't know the case, just make sure that you are prepared as an EMT together with your team, care assistant, and when you reach this the scene or where you're going to get the patient from, you have to make sure that your safety is fast. At least you have to have protected yourself because you don't know what you are going to deal with. Put on proper PPE, reach the scene, reach the site where you're going to get the patient, study the environment because you don't know how much the patient is cautious. Maybe he has soiled himself or herself, and you need to pick from what you've observed, which can help you in your history. You've done well, and you took the patient to the hospital where the primary survey was done. And what I could do be a bit put some caution that you mentioned that this patient had orthopnea, difficulty in breathing while lying down. I don't know how you are carrying this patient. In which position were you carrying the patient? Was he still lying down in that discomfort kind of position, or you kind of propped the patient? I think maybe next time we can put it and we get to know how such patients have been carried when they are from their scene or from the site. Then when we reach the ED, of course, you done the primary survey, the airway, it was patterned. Check the breathing rate. You need to take when you're taking the breathing rate. Was was there any effort in breathing, or that the patient needed some support in some kind of oxygenation? Because given the respiratory rate the patient had, because you had to address the most important thing in primary survey is that when you identify something, you intervene immediately before you go to another step, given that always ABCD, airway, breathing, saturation, and disability. When you, after assessing airway is pattern, go to breathing. In case you find anything wrong, address it there and then, give oxygen, and see if the patient can a bit improve. Go to saturation, put those cannulas, give food if you have to give food, give anything, any medication if you have to give any medication. So before you go to any other step, maybe disability, go back and reassess this patient. Go back to airway. The patient may be cautious on admission, but within no time, he has lost consciousness, and then the airway is being compromised, whereby you need to go back to it, like you need to intervene before even you've done the disability. You go back and intervene in the airway. If the patient needs an OPA or anything else, you intervene and help the patient. Then you proceed as you go, as you already mentioned in your presentation, up to disability, exposure, and the rest. Yeah, thank you.
Thank you so much, Dr. Hamis, for your thoughts. For the questions asked, in the event that the presenter does not have responses, it's still very okay. You could just guide us through what you recommend for that particular thing. Okay, so over to you, Talema.
So, okay. At the emergency department, we carried out the following. We carried out proper positioning so that to protect the airway. We gave her oxygen at 2 liters per minute to improve the SpO2. We gave her a cardiac bed, gave her IV Lasix of 120 milligrams. We got in her blood for lab tests. So, in the sample history, she was an 87-year-old female with non-projectile, non-bloody, non-bilious vomiting, epigastric pain, leg swelling, and dry cough. She had no allergies and no medications taken earlier. She was found at home vomiting, and an ambulance was called.
Team, I think we'll let people post the questions in the chat, and then we shall move on to the next session. In case you have any information you would love to hear from the team, you can type it in the chat, and then we shall have a response either from the team or in case it's an extra explanation, we have experts in the chat that will be able to answer us. So please don't worry. Talema, please proceed. Okay, so at this point, we want to welcome Dr. Hamis back. Do you think our emergency department care was sufficient? Is there something you would have done differently based on what was shared?
Yes, thank you, and thank you, Tarema. At least I was happy that you proctored the patient and you had to put the patient in a cardiac bed, because from the history we are gathering, the problem is originating from the heart. Okay, so yes, you've done well giving oxygen. So me as personally, I like starting with bigger device when I'm administering oxygen. Start with at least 15 liters, and you keep on like degrading down to mask and then to nasal prong, because you don't know what next is going to happen. It's better when the patient is getting enough than again when you give nasal prong and then afterwards you need more, you start looking for NRM. It's better we start with the big one like NRM, and then you go down as the patient uh, uh, responds to that administration. Yes, at least the initial management, the ED, given the primary survey, I, I, I can't add any more on that. At least they did better. Yes, and any addition info for you, if for want to, I know I at least for that case, sometimes ED is a multidisciplinary kind of approach. As you recognize certain problems, you either consult immediately, or in case you have resources, you intervene. For such case, of course, if you had focus, you could do a cardiac focus, you do ECG immediately there and then see what the heart tells you. In case you find maybe the heart has issues like a tamponade or something, a fusion, okay, you do also lung, given that the patient had bilateral basal purpose, you do a focused lung, okay, and see what's happening in the lungs. Then from there, you can consult accordingly or intervene if you are able to. I think that's what I can tell you.
Dr. Shafi, everyone would love to clear. There is a constant question. This patient had vomiting for 2 weeks, and in the emergency department care, there is a constant, and there was no fluid given to this patient. Would you have wanted to give this patient fluid in light of the vomiting or the clinical state of the patient? I think we need to clear this up, and then we move to the next session, to the next section.
Yes, for such patient, given the presentation, I would really I would recommend giving antiemetic, okay, than adding fluid, because given that the lungs are filled, probably that's what you could think. And I don't know, when we further examine, I'm sure that patient would be having ascites and having like kind of fluid overload. So adding that patient more fluids because of he has lost from vomiting too, I wouldn't recommend it than giving antiemetics and observe accordingly.
Okay, so thank you very much. I think as we proceed, we shall get more answers to these questions. Okay, so over to you. Next slide, Talema.
Okay. In our secondary survey, the 87-year-old female had no pallor, she had no jaundice, she had no lymphadenopathy, she had bilateral crepitations, and a systolic murmur at the mitral. She had a mild abdominal distension. It was non-tender and she had no organomegalies. Her extremities were warm with a bilateral pitting edema of grade 3. Her GCS was 14 out of 15 and she was disoriented. The pupils were equal and reactive to light. Her skin was normal. So our problem list, we had respiratory distress, we had vomiting, epigastric pain, basocrackles, grade 3 edema, and irregular pulse, and altered mental status. Our differential diagnosis, since he had difficulty in breathing, we suspected decompensated heart failure, bronchopneumonia, atrial fibrillation, and pulmonary hypertension. She had edema, therefore we suspected again decompensated heart failure, chronic kidney disease, and pulmonary hypertension. She had an irregular pulse, fatigue, and difficulty in breathing, so we suspected atrial fibrillation. She had a systolic murmur at the mitral area, so we suspected valvular heart disease. She had cough, so we suspected decompensated heart failure, bronchopneumonia, and pulmonary edema. She had orthopnea, so we suspected also decompensated heart failure. So on the investigations, she had hyperkalemia of 8.68, hyponatremia of 126 millimoles per liter. She had neutrophilic leukocytosis. She had features of AKI with an elevated creatinine. She had elevated liver enzymes, alanine transferase and aspartate transferase, and the lipid profile was normal.
Okay, thank you so much, Talema. I think we are opening this up to the audience. Anyone to read through this and to eyeball and let us know what they think. Once again, there are no wrong answers here, so because we are learning together. So look at this and give us what your thoughts are on this EKG. You can type in the chat. Maybe we'll give one person a chance to unmute in a minute and just let us know what they see. Okay, Talema, you don't have any volunteers on the in the chat for this EKG. Kindly let us know what your team thought of the EKG, and then we move forward.
So on the
And yes,
EKG,
just let us know the basics that we use to interpret.
so on our EKG, we realize when we check on the P waves, we know that our normal ECG has the P, the QRS waves, and the T waves. So when we check on the P waves, here we are lacking the P waves. There is absence of the P waves. So we suspected atrial fibrillation. Yes, so that's what we thought about.
Okay, thank you. Was supposed to run a poll question at that point, but as the poll is coming through, I think at this point I will invite Dr. Hamis. Dr. Hamis, we've had a look at the results so far. We've had a look at the ED care. Yes, the poll has come through. I think Dr. Hamis, you'll come in after this poll. So we have our poll question. Which of the following ECG findings would be consistent with the diagnosis of atrial fibrillation? I think Talemo has given us a clue, but yes, please, let's keep the responses coming in. We shall stop the quiz at 50% attendance. So one is absence of P waves with irregular RR interval. Regular RR intervals with absent P waves and narrow QRS complexes, sawtooth baseline flatter waves with regular RR intervals at a rate of 150, presence of P waves with a prolonged PR interval. We shall have corrections at the end, so feel free to put in your answers. Let's get to know your thoughts. Okay, we do have 31% coverage. At 50, we shall bring an end to this poll. Okay, so we've hit 51% at coverage, and I'm going to bring this poll to a close, and then we shall bring in Dr. Shafi at this point. So we've had our patient right from pre-hospital. You've listened to the progression, the secondary survey, the immediate ED care, and our findings so far. What are your thoughts at this point?
Yes, thank you, Anna. So, given the information laid out, really this is a critical patient, and is a patient who is at a verge of getting a cardiac arrest at any time. So it's emergent for us to really intervene as as early as possible. If you look at the electrolytes, here's the bad hyperkalemia and and uh, and a bad hyponatremia. If you look at these two electrolytes, they are mainly regulated in the kidneys. And given that sodium is being lost and a lot of potassium is being retained, it brings us a clue on how the kidneys are functioning, especially regarding the hormone aldosterone. So either is a problem with aldosterone release, or the problem is originating in the kidney tubules, which are regulating the these electrolytes. So this is a patient who's, as we talked about earlier on, that he may one of our differentials may be having chronic kidney disease, which is giving us that picture of those kind of electrolytes. However, we didn't pick up on the record of urine output, which could also be very sensitive in our approach to this patient, whether the patient gives out enough urine or is not giving out enough urine. So with that kind of hyperkalemia, of course, we immediately can approach it in giving the patient the medication we are supposed to give, like nebulizing the patient with salbutamol, which will also in also opening up the flooded bronchos, and also helping cells open up for potassium, and also add in calcium gluconate or calcium chloride, and also insulin and dextrose, probably in a way that you are managing uh, hyperkalemia. And also hyponatremia, um, the altered mentation the patient presented, I probably think it's caused by the hyponatremia, which is being evident in the lab results. So in our management, we need to also add some hypertonic saline as we're regulating, because we don't want also to cause overload of fluids and other things. Yes, and also in given that the patient expecting a patient having atrial fibrillation, we need to put this patient on some anticoagulant. In the lab results, it could also help us in case we had the profile of the PT and INR, so that we see how we can initiate the anticoagulant in this kind of patient. Yes, this is the patient whom you really actually, after giving those initial kind of management, you need to consult a cardiologist. Okay, and also a nephrologist, because it's a kind of a patient who happens to have like a cardiorenal kind of syndrome, whereby the heart has affected the kidneys and, and vice versa. So we need to consult other disciplines to come and help in intervening this patient. Yes, Anna.
Okay, thank you very much, Dr. Shafi. To me, this is an interesting patient that that can surprise the team. because the way they presented, and then it looks like if you are not a very critical doctor, you would easily miss most of these things because they're presenting complaints. You can get locked in the vomiting and then miss the nice things that this patient presents with that could actually have killed this patient faster. Yeah. Otherwise, thank you so much for your input. So let's see what the team was able to do. Over to you, Talema.
So a cardiac echo was carried out, and it showed bilateral enlargement with dilated left ventricular systolic dysfunction, a grade 3 left ventricular diastolic dysfunction, and severe pulmonary hypertension.
Again, at this point, we bring in Dr. Shafi again. Given the findings and the new inputs that you've had, is there something you would want to change? Could your management plan be different? Could your diagnosis be different? Anything you would tip us in at this point, if it's different from what you've discussed? You're welcome.
Yes. Thank you, Anna. I won't really deviate much from the differentials being shared. Only that because we have now a picture of electrolyte imbalance, then we can bring in that, and also we can also think about uh, aldosterone, okay, whether it's being low or what. Yeah, something like that. So we need. I will not deviate much from all the differentials which were pointed out. And in the management, what I could say that uh, given the picture of the patient and the lab results, when we are managing such patients, we really don't we need to manage patients holistically and and individually. We shouldn't uh, uh, manage patients. Sometimes we should also avoid managing patients symptomatically, because sometimes if you manage a symptom and you not manage the cause, it will still recur. So we need to look at what's the cause of that. Yes, the patient had the gastric pain and what which people could think about. Oh, the patient had a gastritis, severe gastritis, and what. But this is stress-induced gastritis, which is pictured from the stress the body is going through of the heart issue, of the kidney issues, okay, of electrolyte issues, and that stress triggers the gastritis. So if you focus on gastritis, you miss up managing what really has triggered that gastritis. So you manage the patient holistically, stemming from the root cause. Okay, as from the pictures we've seen, the issue is in the kidney, and for such patients really, and with such kind of hyperkalemia, with such kind of edema and other things, this is a patient who may need dialysis. So in all our management outs, we've done the fluids, the Lasix to put out the fluids, to help this patient to oxygen and what, given some heart antiarrhythmias, anticoagulants and what. We also need to think about dialysis, given that kind of picture. So in our investigation, we didn't, if I'm to beg your pardon, I didn't get the picture of the, the, the arterial blood gas, which could also help us. However much we had the electrolytes, but also need to see the arterial blood gas to see with how acidic was this patient, and to say we can initiate dialysis as quickly as possible. Yes. Yes, Anna.
Okay, thank you so much, Dr. Shafi, for your thoughts. Yes, Talema, over to you. What did your team manage and what did you conclude with?
So our team was managing decompensated heart failure with atrial fibrillation, severe hyperkalemia with moderate hyponatremia, as well as suspected chronic kidney disease, and then peptic ulcer disease secondary to H. pylori.
So right about this time, we shall have a poll question running, and as it comes through, maybe what I would personally take from this case is that yes, it's coming through. We had an 87-year-old female patient has a third VAS score of 4 due to age of greater than 75, heart failure, and hypertension. What is the recommended approach for care of these patients? One is initiate aspirin 75 milligrams daily as she's at low risk for bleeding. Initiate a DOAC, that's, for example, a Pixaban, only after the rhythm control strategy has been successful. Initiate warfarin with a target INR of 2 to 3, preferred over the DOACs in elderly patients. And then 4, initiate a DOAC in preference to the VKS. So you can choose for us vitamin K. You can choose for us what um, you think is the best option. Okay, just keep the polls running, and I think I'll do my voiceovers as mentioning. This is an interesting case that I think keeps highlighting for us the importance of having to do a thorough primary survey for patients. It doesn't matter, uh, even when the patient is talking to you, look out for these things because the whole essence of the primary survey is to be able to identify life-threatening presentations to these patients. And you do it systematically, do it thoroughly, because realize this team was able to pick problems within the first within the first 5 minutes. They picked up what these patients' problems were, and it guided the secondary survey, it guided the detailed history, it guided the investigations. And if you just came up and took a history, you'll spend the time to, for example, take a history, but when you've not gotten the immediate things that could actually even guide the remaining part of your care. So this case opens our eyes to something very important, and I hope it, if you don't pick anything from this case today, pick it that um, do remember to always do a thorough and detailed primary survey for your patients. It doesn't matter what the presenting complaint is, and it doesn't matter if the sometimes patients can have distracting presentations, and you will rush and focus on what the patient presented with. Yet, what's killing the patient is looking at you and maybe C or B. So it teaches us something very important, and for me, it's personally a take-home message for me. Okay, so the quizzes are at 53%, and right about this time, I'll close off this poll question and call in Talema to continue with the care that was initiated.
So our management We gave her an antiemetic of IV ondansetron, 8 milligrams. So we gave her tolvaptan for hyponatremia management, gave furosemide. We gave her furosemide, IV calcium gluconate, kayexalate, IV insulin 10 international units in 30 ml of dextrose, 50%. All those were for the electrolyte imbalance management. We gave her apixaban, 2.5 milligrams, and bisoprol, 10 milligrams, for atrial fibrillation management. We gave her IV omeprazole for the peptic ulcer disease. We gave her captopril, 25 milligrams, for the hypertension. We also gave her IV ceftriaxone and lactulose.
Okay, thank you so much, Salema, for highlighting for us what your team included in the care of this particular patient. Would like to welcome Dr. Shafi to give us his pulse and pitfalls. Personally, I think what I would request to emphasize for the team is one, when it comes to AFib, because some of the questions that have been coming through was prioritizing the rate, prioritizing the rhythm, and then looking at the anticoagulation, and then looking at managing the hemodynamics of the patient. So for me, those questions kept recurring, and I think it would be good to clarify on that. Over to you, Dr. Shafi. Thank you.
Yes, thank you, Anna. So this was an interesting case because patient had more than 3 organ dysfunction. Okay, so is a multidisciplinary kind of patient whom you not need to die alone in the ED or trying to act hero. So you need to bring in other colleagues and manage such patient. The moment you help, you intervene in your primary survey, and the patient is out of danger in those the first 5 minutes, and you realize that this is a patient who is complex and may need assistance. Things what you have to avoid is dying alone or playing hero. You need to consult in such cases. Okay. And the practical bit of is that always examine thoroughly, do your thorough kind of primary survey, and always reassess such patient. Okay, we've seen that the patient was conscious, but let alone the ED, this is a patient who had altered the mental state. So this patient keeps on deteriorating. So if you don't keep on reassessing your patient, you may end up managing a dead patient, thinking that the patient is breathing and is doing what. Okay, so you need to do what to keep reassessing such patients in the ED, and always be observant. Okay, there are certain things these patients do, like they are because of the conditions they are facing, okay, or the conditions they are having, and for you may take it for granted, like patient batawanya kati aleekaana biki. So yet the patient is delirious or having some issues with the brain. Okay? So always be observant, okay, and always do a thorough examination of such patients. Okay, so that's what I can I can share. It I can share with the team. Yes, but let's always consult our colleagues in other departments. Yes. Yes, Anna, over to you. I don't know in case there's anything else I could add.
Okay, thank you very much. Over to you, Talema. We could just wrap up this case in the next 5 minutes. You let us know what was the prognosis of this patient, and then what was your disposition plan at the point from emergency department? Actually interested, what was the team thinking about disposition, and then what are your take-home messages from this case?
Okay, so our hospital case, on day one, we found out that the patient had the hyperkalemia, the hyponatremia, the neutrophilic leukocytosis, edema, a GCS of 13 out of 15, and the elevated creatinine. We gave the above management plan as read for you above there. Then on day two, we realized, on day one we inserted a urinary catheter, and on day two we realized there was a reduced urine output of 300 ml in 12 hours, epigastric tenderness, failure at pass stool, and an elevated creatinine, hyperkalemia, and hyponatremia. Yeah, on the above management, we added lactulose of 20 ml, 8 hourly. Day three, the GCS reduced up to 10 out of 15, and she had a hepatomegaly. We repeated the labs, requested for CRP. We gave her the IV 3% hypertonic saline, IV albumin, and we also requested for an abdominal ultrasound scan. Yeah, on our day 10, yeah, her blood pressure reduced up to 78 out of 57. Her mean arterial pressure was 57. She had a tachycardia of 115 beats per minute. She was immediately admitted to HDU, where they gave her 13 liters per minute of oxygen. Though unfortunately we lost our patient, may her soul rest in peace.
Okay, thank you, Talema. Just from this slide, I know expert is done, but just wanted to bring up the important points he actually shared that I think we could pick from this case, because we didn't anticipate the, okay, maybe we procrastinated and we did not over anticipate the problems that this patient could have. There was a question in the chat that where Dr. Shafi said, usually for patients that are having moderate or severe distress, he would rather start high and keep tapering down the oxygen rather than starting low and then go high. The question was, there was a worry over oxygenating this patient. True, but you notice that the patient later on, sometimes the pulse oximetry is a late will give us a late measure of hypoxia or hypoxemia. So the ideal is capnography, which we do not do in our setting. So sometimes going higher and monitoring this patient, and as you titrate downwards is better, because you notice the patient later on actually did need better oxygenation, but we had lost time for this particular patient. And then there was a question on what was the actual cause of auto-admittation in this patient. And then from day one, I think day one tried to answer some of these questions for this patient. We did have a hyponatremia. And again, for elderly patients, these small electrolyte changes can be significant to actually give us big problems. And by the time you're thinking of correcting them, it's already too late. The patient started with a 126, which was moderate, and the team at that point did not, I don't know if they forgot or they waited to initiate it later, but our hyponatremia management was a little late. And for an elderly person who was not feeding well, who was vomiting, orals could not have been an option. Maybe the hypertonic saline could have come in a little earlier. And then we also noticed the patient had a leukocytosis. So maybe we also had some sepsis that kept uh, competing and killing our organs faster and further and contributing to the whole sickening picture. Maybe the team could have done blood cultures, like a complete septic screen for this patient, and established for sure that uh, sepsis was not a big contributor to the worsening clinical picture for the patient. And then you notice, if you notice, all those things kept worsening as we went down. And by the time we were on day 10, why I particularly asked what was the disposition plan for this patient, I think it's a patient that could have actually been admitted to an HDU or ICU a little earlier. I understand we do not have space, but maybe it should have been anticipated a little earlier because we already had 3 organs that were failing at the start. Yeah, so this is a very good write-up for us to reflect, because the patient seemed to come in with small problems, was vomiting, was having lower limb weakness, was still a bit more conscious, and we could have focused on things actually when the patient is having bigger problems in their organs that we could have picked out with a detailed exam and actually being more what anticipating these problems a little earlier. Yeah, so I hope, Talemwa, as you give us your take home message, we are winding up. Uh, what would you have done differently for this patient? And then you give us your take home message. Yeah, those are just my thoughts on from this layout of the chronology of the days as the patient progressed through your care. Knowing what you know now, what could you have done for the patient differently? Or if you were the only or the senior doctor managing the patient, what could you have done differently? And then maybe you give us your take home message from the patient. Thank you.
Okay, yeah, thank you, Dr. Ann. Yeah, what I would have done differently: one, carrying out a thorough abdominal examination and look out for any other precipitating factor in there, as well as starting up the 3% hypertonic saline, yet to handle the hyponatremia. Yes, that's what I would have done differently. So, our take-home message, yeah, we shall just get adequate some info about atrial fibrillation. Yeah, so our patient had a decompensated heart failure with atrial fibrillation, and this is one of the commonest sustained arrhythmia, and it's characterized by disorganized atrial activity and contractions resulting in an irregular ventricular response. It is normally due to rapid bursts of ectopic beats from the conducting tissue, the pulmonary veins, or from a diseased atrial tissue. So we have 3 types of atrial fibrillation which are commonly known. The paroxysmal atrial fibrillation, which is mostly self-terminating. The persistent atrial fibrillation, which is normally greater than 7 days but can be terminated normally by cardioversion, as well as the permanent atrial fibrillation, which cannot be terminated by cardioversion. So the common causes here have been summarized in mnemonic pirates. The P standing for the pulmonary causes, the pulmonary embolism, the COPD, the pneumonia, the I standing for the ischemia or an infection, the R standing for the rheumatic heart disease, A standing for alcohol, anemia, atriomyxoma as well as age, the T standing for thyrotoxicosis, and toxins. The E standing for the electrolyte abnormalities and endocarditis. The A standing for sepsis and surgery. We have other causes apart from those ones we have listed above, such as sinoatrial node disease, the congenital diseases, pericardial diseases, and unknown causes stroke idiopathic. So we have our CHAD score, the CHAD VASC score. This is normally used to assess for the risks of stroke. In patients with atrial fibrillation, they normally have a thromboembolism as well as high risks of stroke. Therefore, we use this CHAD VASC score to determine the risk of stroke, where the C stands for congestive heart failure, the H stands for hypertension, the C, congestive heart failure carrying 1, congestive hypertension carrying 1, A standing for age, which is greater than 75, carrying 2, the D carrying diabetes mellitus and has 1, S for previous stroke and carries 2, any vascular disease, then any age which is between 65 and 74 years and carries 1, and the SC stands for sex category, mostly the females, and carries 1. So any CHAD score greater than or equal to 3, we start anticoagulants immediately. So in case you get any patient with an irregular pulse at the emergency department, you are expected to carry out a bedside ECG, anterior blood gases, and a cardiac echo. Yeah, you have to carry out electrolytes, mostly the calcium, the magnesium, the potassium, the phosphates. You have to carry out thyroid function tests. You have to carry out a complete blood count. Carry out the imaging such as the chest X-ray to check out for a cardiomegaly, atrial dilation, or pulmonary edema. Carry out an echo to check out for the structural abnormalities, as well as to a tracheoesophageal echo to exclude atrial thrombus. So,
Okay, Talema, in 1 minute, just wrap up this because we've had a detailed discussion. Just wrap it up for us.
So in our management, ensure that you identify all the comorbidities such as the hypertension and all the comorbidities that may be in a given patient, and you manage them immediately. Yeah, you assess for stroke risks and you manage it immediately. Then you can carry out a rate or a rhythm control. A rate control, you can use beta blockers or verapamil or any calcium or digoxin. Then you have to carry out a rhythm control, which can be where you can use flecainide or amiodarone. Though when using amiodarone, this amiodarone has 40% iodine. Therefore, you have to monitor your thyroid functional tests to avoid hypothyroidism. So take note of it. Then After managing all the above, evaluate the progress of the patient and assess for the different comorbidities so that you can get your patient back to normal. Yeah, so the different types of the treatment, paroxysmal atrial fibrillation helped use beta blockers. That's why we brought in bisoprolol immediately. Then for the persistent atrial fibrillation, you use amiodarone, but monitor the thyroid function tests. Yeah, you can also carry out electrocardioversion for the persistent atrial fibrillation. Yeah, so for the permanent atrial fibrillation, carry out ambulation. Yeah, thank you very much.
Thank you, Talema. Thank you to our crew this week. Big up to you guys. Thank you, Angel. Thank you, Talema. Thank you, Dr. Shafi. This was an interesting case.
Yes.
And I would like to, yes.
Yes, Anna, just baganda se akatalekeka. So I would just this goes to the team, okay, especially managing patients at the ED. It's very important for you to recognize critical patients and know their destinations, where they are going to be disposed to. I'm surprised that this patient was taken to HDU on day 10. This was a patient who was supposed actually to go to ICU that very day after getting like all the lab results and realized that this patient is having more than two organ dysfunction because it's one of the criteria for admission to ICU in some institutions. So it was not. Let me say that they did that to such a patient to manage such a patient on ward. Okay, and from the management plan, I've not seen where they consult other specialists to come in and give their opinion regarding such a critical patient. It's really prudent for us to always consult our like other disciplines, other specialties. For this, the patient needed more than three specialties. He needed a nephrologist, needed a cardiologist, okay? He needed even a pulmonologist. You get. So if we tend to cocoon and manage such critical patients, they end up dying, just like this one. Okay, and there are certain interventions which we need to employ in as early as possible. This patient needed dialysis from day one or day two, from the day we observed his labs and his clinical state. So let's be vigilant when we are really handling some critical patients, and let's yeah, what I can say, let's consult and refer when it's due. Okay. Yeah. Thank you so much.
Okay, thank you so much, Dr. Shafi. And to the team, thank you all for hanging in here. We are almost 15 minutes past our time of ending this session, and we want to bring this to a close. We want to say thank you to the team that is behind the desk organizing this, to the CPC team. Shout out to you all, you guys. Thank you so much for being diligent and for organizing these sessions for us every other month. For anyone that's, again, I'll keep re-echoing, if you get an interesting case, an interesting patient, let's learn together. Let's make ourselves better. Reach out to Dr. Erica. She's in charge of picking these cases, or join our CPC forum. Welcome all sorts of cases. The better if you have a mentor. Thank you for joining in. See you next time, and bye.